Welcome to the Head and Neck Oncology Journal Club. I'm your host, and today we are covering a landmark trial that could change practice for hundreds of thousands of thyroid cancer patients worldwide. This is the IoN trial published in the Lancet in June 2025. The question is simple but important. After total thyroidectomy for low risk differentiated thyroid cancer, do patients actually need postoperative radioiodine ablation? For decades, the answer was yes, give the radioiodine. But is that based on strong evidence? Let's find out. So here's the background. Thyroid cancer is the seventh most common cancer globally, with over 821,000 new cases per year. The vast majority are well differentiated thyroid cancers with excellent cure rates. Since the 1950s, the standard practice has been total thyroidectomy followed by radioiodine ablation using iodine 131 to destroy any remaining thyroid tissue and potential microscopic disease. But here's the issue. Radioiodine ablation comes with real burdens, radiation safety precautions, side effects like dry mouth and fatigue, and most importantly, patients must avoid close contact with children for days afterwards. For parents of young children, that last requirement can be particularly challenging. A prior French trial, Estimable 2, showed that patients with very small tumors, PT1A and PT1B, N0 or NX, could safely skip ablation. But what about patients with slightly larger PT2 tumors? And what about long-term outcomes? That's exactly what IoN trial set out to answer. Let me walk you through the study design. IoN was a multicenter, open-label, randomized, non-inferiority trial conducted at 33 cancer centers across the UK. Eligible patients had differentiated thyroid cancer, papillary or follicular, with complete R0 resection after total thyroidectomy. They could have PT1, PT2, or even PT3 tumors with N0, NX, or N1A nodal status. Patients were randomized 1:1, either 1.1 gigabecquerels of iodine 131 ablation or no ablation at all. The primary endpoint was 5-year recurrence-free survival. Non-inferiority was assessed with a margin of 5 percentage points. Now let's talk about who was in the trial. 504 patients were enrolled between 2012 and 2020. 77% were female. Median age was 47 to 48 years. For tumor stage, 47% were PT1, 44% were PT2, and 9% were T3 or PT3A. 91% had N0 or NX nodal status, while 9% had an N1A disease. The median follow-up was 6.7 years, and 77% of patients had at least 5 years of follow-up. This is important. We are looking at long-term outcomes here. All right, here's what everyone wants to know, the results. The 5-year recurrence-free rate was 97.9% in the no ablation group versus 96.3% in the ablation group. Let me repeat that patients who skipped radioiodine actually had a slightly higher recurrence-free rate, though not statistically different. The p-value for non-inferiority was 0.033. This met the pre-specified threshold, proving that no ablation was non-inferior to the ablation group. In total, only 17 patients had recurrence across both groups, 8 in the no ablation arm and 9 in the ablation arm. What about the pattern of recurrence? When they occurred, most were in the thyroid bed or cervical lymph nodes. Only one lymph node had distant metastatic disease to the lung, and importantly, this patient did not have high-risk features at the baseline. Most recurrences, 76%, occurred within first 3 years, but some appeared as late as 4 to 7 years, which emphasizes the importance of long-term follow-up. Now, here's where I need to add an important caveat. The overall non-inferiority conclusion applies to the study population, but subgroup analysis revealed some signals we can't ignore. Patients with PT3 or PT3A tumors had a 9% recurrence rate overall compared to just 3% for T1 or T2 tumors. Patients with N1A nodal disease had a 13% recurrence rate compared to only 2% for N0 or NX. Now, crucially, within these high recurrence subgroups, recurrence rates were not higher in patients who skipped ablation compared to those who received it, but the subgroups were small and underpowered. So the investigators made a clinical decision. They cannot confidently recommend for or against ablation for PT3, PT3A, or N1A disease based on this trial alone. Let's look at the safety data. Adverse events were similar between groups. The most common were fatigue 25% versus 28%, lethargy 14% in both groups, and dry mouth 10% versus 9%. Quality of life scores showed no meaningful difference between the groups at 2 months. But here's a practical consideration that really matters. Patients who received ablation had to avoid close physical contact with children for a median of 4 days after discharge. For patients of young children, skipping this requirement is a major benefit. There is also a health economics angle here. The trial calculated cost savings. For every 100 patients who skip ablation, the NHS saves approximately 213,000 pounds. That's over 270,000 US dollars. If applied to the estimated 400,000 patients worldwide who meet the eligibility criteria each year, the global healthcare savings would be enormous. So what does all this mean for ER practice? First, for patients with PT1 or PT2 tumors, N0 or NX nodal status, and no adverse histological features, radioiodine ablation can now be safely omitted. This doubles the number of patients who can avoid ablation compared to the estimable 2. Second, for patients with PT3, PT3A, or N1A disease, the evidence is insufficient to change current practice. Clinicians should continue their usual approach, though shared decision making is reasonable for select patients with favorable features like low thyroglobulin. Thirdly, patients who skip ablation should have thyroglobulin monitored every 6 to 12 months with annual neck ultrasound for at least 3 to 5 years. And fourth, a post-surgical thyroglobulin level of 2 nanograms per milliliter or higher identified about 56% of the recurrences and may warrant closer surveillance. Now, let me wrap this up with a bottom line. In the IoN trial, combined with estimable 2, provides level 1 evidence that most patients with low-risk differentiated thyroid cancer can safely skip radioiodine ablation after thyroidectomy. This applies to PT1 and PT2 tumors with N0 or NX nodal status and no adverse features. The benefits are clear: no radiation exposure, no need to avoid children, and substantial cost savings, all without compromising oncological outcomes over nearly 7 years of follow-up. For PT3 or N1A disease, clinicians should continue current practice while awaiting further data. That's the IoN trial. The full paper is in the Lancet. I'm giving the DOI link. Thanks for joining the Head and Neck Oncology Journal Club. If you found this useful, subscribe to our newsletter and share with your colleagues. Until next time, stay evidence-based. Thank you.